and welcome to the Rob Call Bottom Up Show, available on Pacifica Radio Network and iTunes and Stitcher and SoundCloud. The most comprehensive archives of the show are at opednews.com/podcasts with an S. And I'm glad to have on the show Mike Magee, MD. He's the author of Code Blue, and the subtitle is Inside America's Medical Industrial Complex. And then the subtitle is Profit Over Health, the fascinating, infuriating story of how we built the world's most expensive, least equitable healthcare system and what we can do to fix it. So, welcome to the show.
Well, thanks, Rob. I really appreciate being invited to be part of the discussion here.
So let me give a little bit more of your background. You're a medical historian and journalist. You're on the faculty at the University of Hartford, and you were the head of global medical affairs for Pfizer. You're the author of this book, and your website is mikemagee.org, M-A-G-E-E, and another one is healthcommentary.org. Okay, so let's get started. This is a really hot topic now. I'm looking at the latest polls for the presidential candidates, and healthcare is the #1 issue for people.
Absolutely.
So, why did you write this book, and what are the most important messages you want to get across?
Well, I had seen healthcare from every angle. I really started out in the middle of your bottom-up revolution. My dad was a doctor whose office was attached to the house, and there were people from the small towns around us who never made appointments. They just came over and waited in line to see my dad. And watching him take care of people, he was a doctor who was about the little guy. He was there to help them and to help the community. And that's the kind of doctor I wanted to be. Over the years, I trained as a surgeon in North Carolina and then went up and practiced in a little rural community right below Brattleboro, Vermont for 10 years. And in that community, it just reinforced the goodness that healthcare can bring to the people if it's available to all. From there, I went to hospitals and to medical school management and ultimately to Pfizer. And along the way, what I learned is that...
I'm sorry, I'm smiling because of the way you said Pfizer.
Well, along the way, what I learned is that everybody was cut into the deal except for the patient. $1 in $5 in America devoted to this thing, twice as much as any other country. And yet the people, especially the people who are in the low and middle income areas, were faced with tremendous insecurity. I mean, how in a country do you spend twice as much as everybody else? And yet you have 20 to 50 million people who are either uninsured or seriously underinsured to the point of fearing bankruptcy if they happen to have the bad luck to get sick. So when I was at Pfizer, I became disillusioned and slowly but surely was trying to figure this out. And finally, in 2007, I quit. And I spent the next 10 years connecting the dots, trying to understand, what's going on here. And everybody always said to me, it's too complicated for you to understand. And finally, I came to the conclusion, which I think is reflected in Code Blue, where, yes, it's complicated, but the important thing to realize is it's complicated on purpose. The more complicated it is, the less you know. The less you know, the more you pay. And so what I tried to do was to pull the veil back, explain to people how we got this crazy system that we have and what we can do about it now.
Well, how did we get this crazy system?
Well, I think the major origins of it are in World War II. We basically, in order to win World War II, had to ramp up both equipment and manpower very rapidly. And what the experts in capitalism told FDR is that if you're going to get these corporations to go along with what you want them to do, you got to pay them well. And so we began not only to pay these corporations to ramp up quickly, but also we encouraged people from all walks of life to collaborate with each other and gave them all a good pocket lining of income if they were successful in collaborating with each other. And we said, these cross-sector collaborations are going to create ingenuity and help us win the war. Well, when the war ended, what our experts said was, well, if we were to defeat disease the way we defeated the Nazis, health would be left in its wake. And that was the fundamental original sin of the system. Instead of saying, how do we make America and Americans healthy? What we said was, how do we defeat disease? And we've been chasing disease ever since. And what's happened is corporations have gotten richer and richer, and our people have gotten poorer and sicker.
And actually, when I think about it, you talk about this, and you talk about the Lasker family and NIH and how NIH focuses specifically on disease. It makes me think of a couple things. One, I've been a lot involved in positive psychology over the years. And one of the reasons I got into positive psychology is I started thinking about how you could make people mentally healthier and happier by taking an approach of giving them skills for being happy and healthy rather than just addressing the pathology. And what you're describing is something similar in healthcare. And I don't, my guess is there isn't that much research or investment in how to get people to be healthy and stay healthy and motivate them to do that.
Absolutely right. I mean, there's not much investment, and also there's very little in the educational curriculum of doctors that's geared toward holistic health, hardly none. I mean, it's interesting that we are the only nation in the world that spends more on delivering health services than we do on all other social determinants of health combined, more combined on safety and security, on environmental health, on good housing, on proper nutrition. We spend it all on intervening with diseases that are caused by the fact that we underinvest in creating actual healthy communities. So in order to turn this around, you literally have to begin where we missed the ball. And that was, we got to sit down in this country and we've got to ask ourselves, how do we create a healthy America?
So in your chapter that gets into the war on disease, you talk about the Lasker family and NIH, and get into that a little more detail. What happened there? How did that happen? What's the history of that? You're a medical historian. This is the kind of stuff that must be your meat and potatoes there.
Yeah, well, what basically happened was people like Mary Lasker were well-intentioned people. Basically, they were people who had access to vast resources and an interest in philanthropy. Mary Lasker married Albert Lasker. She was his third wife. And he loved her deeply and was willing to invest all his time and energy in her success and her interests. As the father of modern advertising in the US, he knew how to get people to do what he wanted them to do. And so when Mary came to him in the early 1940s and said, what I really want to do is focus on medical research and finding cures for cancer and other diseases that have affected my loved ones, Albert said, well, I can show you how to do that. And they knew that they needed a platform, an advertising platform, in order to be successful. And they also knew that they needed the credibility of professional medicine in order to pursue these goals. So what they did is they approached the precursor of the American Cancer Society, and they convinced them to take their money in return for a board seat. Well, the rest is predictable. Within 5 or so years, they had control over that organization. They threw the leaders of the organization off, and they brought in all of their corporate friends to serve on the board, and they changed the name of this organization to the American Cancer Society. Off of the back of the American Cancer Society and with their contacts in New York City media, they were able then to launch with Truman, and the presidents followed every one of them, Eisenhower and LBJ and JFK. they were able to not only get the federal government to invest huge amounts of money in this new organization called the National Institute of Health, but Mary Lasker herself and those who aligned with her, which were some of the major medical figures in the world, they aligned with her because that got them access to money and funds. It got them access to NIH groups. It got them access to speaking roles that they wanted. It got them access to new jobs at big academic institutions. In return for cooperating with Mary Lasker, Mary had the clout then to begin to define what disease areas would be treated as part of the Institute of Health. Well, by the time, we got a couple of decades forward, we had 17 or so National Institutes of Health. All of these were in the disease areas that Mary Lasker herself considered to be important. So the point of all this is that it emphasizes the fact that one of the problems with U.S. healthcare and why we're in the mess we're in is we never had professional planning. We never planned out a healthcare system. We've got no plan for health in this country. What we have is a series of even well-intentioned thrust areas for one disease or another. Mary Lasker famously ran an ad in the New York Times and Wall Street Journal, a full-page ad challenging Nixon to engage in a war on cancer. And so we've been warring on things like cancer and Alzheimer's disease and so on and so forth all these years. And yet, when you look at something like maternal fatalities during pregnancy, in this country, we have 24 per 100,000. In two countries whose national health insurance systems, national healthcare systems, we rebuilt after World War II, Germany and Japan, our two arch enemies, we rebuilt and created national healthcare systems at the same time that we denied this to our own citizens. In those two countries today, their maternal fatality rates are 6 per 100,000 and 7 per 100,000. 1/4 of the deaths that we have in our own country. And yet, even though we rebuilt their systems, national systems that were universal healthcare systems like we should have here in this country, where we pay twice as much, and we have many, many, many Americans that aren't even covered by insurance, we have fatality rates that are 4 times greater. We also have, as our number 3 killer of adults in the US, hospital preventable deaths.
Iatrogenic death.
Yes. And so you have to ask yourself, what's gone wrong? I mean, anybody who is sensible who would say, like Warren Buffett has, that this healthcare system is the tapeworm on Americans' economic competitiveness. Obviously, if we are failing, if we have such a dismal performance and are paying twice as much, something must be wrong that is very, very fundamental. And the case that I make in Code Blue is that what is wrong is we've got no plan. We've got no plan for health. We have not got a fundamental understanding even of what contributes to a good, healthy community and environment.
Well,
and that's where we got to go back to.
Well, what you make me think of is that science has transitioned from an atomistic, mechanistic model where we take things apart and count them to a systems model where we look at relationships and patterns. And NIH and our healthcare system, the way you're describing it, is based on this atomistic, mechanistic model that we know does not work for the most complex things. And
here's what it does work for, though, Ron. It works for your career. Rob, I'm sorry. Rob, it works for your career. An integrated career ladder. You can go from academic hospital to government to corporations and back again. And as long as you get along and go along, you're very, very successful in your career. And so because it was built that way, because the Mary Laskers of the world supported that integrated career ladder, we have a system that just constantly focuses on disease because that's where professional success lies. You don't get great national professional success by being an everyday good doctor like my father was. And that's why we got to revisit this in a very fundamental way.
And it's gotten so much worse. I mean, you were telling me how your father had his office next to his house, and a lot of doctors used to do that. And now, doctors in private practice are almost obsolete because their practices have been bought by hospitals, and then the hospitals are being bought up. It's just gone to an even more heavy top-down system where it's all centralized. And what do we lose when that happens?
Well, I had a call yesterday from a Bloomberg reporter, and she was asking me whether there was a danger in applying artificial intelligence to healthcare. And my answer was that what data-driven approaches can do when they're misapplied and when they're biased, is that they can magnify our mistakes. So if you have corporate interests that control the collection and analysis and creation of algorithms from data, you should not be surprised if the resulting algorithms support the profitability goals of corporations. What will AI be used for in healthcare? We see already some signs that it's being used to identify a broader market for various pharmaceuticals. Now, is that an appropriate goal if you're pursuing health, to take the country that is one of only 2 in the world that allows direct-to-consumer advertising, who takes a country who arguably has physicians that are the sloppiest prescribers, who takes a country where the appetite for pharmaceuticals among its citizens is the largest by far in the world? Is it smart then to take data, which is now under the control of pharmacy benefit managers, the PBMs controlled by CVS and others, to allow them to now direct the future of healthcare delivery and reimbursement to the goals of these corporate entities? I think it's decidedly unwise. And one of the simple outputs of asking the question, what would it take to make America healthy, is we would be forced to create a body that would actually answer that question. And who would those experts be? Would they be the same ones that we have driving the FDA and the NIH now? Or would they be a broader group of citizens who understood healthcare in its most fundamental terms? So I think we got a leadership problem. We certainly have an economic problem, and I think we're not doing well.
We have a paradigm problem from what you're describing. What you're talking about is totally revamping the way we think about helping people to be healthy.
Absolutely.
And just looking at the medical model, the healthcare model, which is really the illness diagnosis and treatment model.
Yep.
You're basically describing a problem that, to be solved, has to be really replaced with something profoundly different. Now, does that exist in other countries?
Absolutely. There was a religious leader who addressed the AMA back in the late 1990s, and he was reflecting on the healthcare systems in other countries around the world. And he said, you know what I want to tell you, doctors? He said, there are 4 words in the English language that have common English roots. They are heal, health, whole, and holy. And he said, and here's why I'm telling you doctors this. He said, to heal in a modern world, you've got to provide health. And if you're going to provide health, you've got to keep the individual, the family, and the community whole. And he said, if you doctors could do that, that would be a holy thing. So I think in those 4 words, heal, health, whole, and holy, captures the potential for what we could do with this massive investment. I'm optimistic because 1 in $5 are already committed to this thing. We already know that somewhere between 10 and 30% of that is totally wasted and could be reapplied. But in order to do that, we have to have the guts to establish true leadership for health in this country, something we've never had.
So you say in the book that the American healthcare system is in critical condition and urgently needs resuscitation. Now, you've already begun talking about it, but can describe what you're seeing as the worst problems.
Well, I think the worst problems probably begin with the fact that we are moving rapidly to a data-driven approach, and our data is already corrupted. There is ample evidence that our research data has been fudged and geared up to answer the questions the way researchers and corporations want them to be answered. We've tended to publish good results and leave unpublished negative results. We have all sorts of problems with our research apparatus and its reliability. Secondly, we have eliminated all of the checks and balances that would normally control corporate overreach in this country in healthcare. And we've gone one step even farther than that. We've allowed the development of PBMs, pharmacy benefit management companies, which deal in hospitals, doctors, insurance companies, and pharmaceutical companies. And they are allowed to have legal kickbacks to each other that are totally opaque. The only one who doesn't know what's going on is the patient who shows up at the counter and pays whatever they have to pay. So we have a system that has a built-in legal collusive network that are all on the take. And I think the third thing is we have a system that is purposefully complex. You know, Trump said, who knew that healthcare could be so complicated? Well, the point is, yeah, it is complicated, but it's complicated on purpose. The more complicated it is, the less you know. The less you know, the more we all have to pay. And so what we need to do is eliminate some of this complexity. There was a study of the billing and insurance-related costs, just the billing and insurance-related costs in this country back in 2014 that found that 15% could be lopped off of the total healthcare bill just by simplifying billing and insurance-related costs. That's why Bernie Sanders wants a single-payer system. It isn't to pursue socialism. It's basically to simplify the billing and insurance-related costs. In addition to that waste, we also have, obviously, a system that because you're getting paid for everything you perform, we tend to overperform. And in general, we've left our patients uninformed as we overperform. The doctors, the hospitals get paid, and the patients are left to wonder, what happened here? Why am I still ill? Why have I not been cured like I was promised to be cured? So the system basically then is got the control systems on information in the wrong hands. It overpays people who have clearly shown that they're profiteers. And at the end of the day, it has left the patients dealt out of the whole system and not prepared yet to pursue their own health.
So just to take another little step back, really, define what the medical industrial complex is to you.
Well, the medical industrial complex is a collusive network of major corporations who basically have aligned their government relations programs, put their government relations programs on steroids in order to sequentially eliminate proper checks and balances. So, for example, in the early 1980s under Reagan, they were able to accomplish the release of government patents. The patents on discoveries that had come out of NIH grant money used to be the public's property. But at the time, there was a recession going on. There was a great focus on wanting to gin up the economy. And basically they said the way to do this is to let corporations take over all these patents. So 28,000 patents overnight were released, and they went on a tear. When they were released to the doctors in the academic institutions that had made these discoveries and the institutions themselves. But those institutions like Columbia Presbyterian or Johns Hopkins or Cornell, the first thing they did was to go to the Pfizers and the Novartises of the world and say, would you like to contribute, 10, 20, $50 million, and we could go at this in partnership. Within a decade, what we see is these large institutions wandering away from direct patient care. They've got glass palaces for their biotech institutions, great cancer fighting kind of operations. And then they're implanted in the NIH advisory groups, and
they run the NIH. Usually the guy running it is a former pharmaceutical company guy or a medical device guy.
And the reality is, I don't have anything against discoveries. I'm all for it. If a MD, PhD wants to become a researcher, go for it. But I don't like to confuse that with a doctor like my father, whose major focus was, number one, on the patient, and number two, on helping to train other people to be doctors like him. I don't want to confuse that with biotech research. So my feeling is that those MDs who want to really be researchers go off and become a researcher. And I'd like to get you registered as a lobbyist, because you're bringing down 100 or 200 or 300,000 a year from Pfizer or one of the other companies. So you're taking their money. In my eyes, you're a lobbyist. So if you're going to be an MD, PhD on an NIH board, and you have that kind of a background, I don't want you to be considered a godly doctor like my father. I want you to be considered an entrepreneurial researcher who's trying to make a discovery that will get both a Nobel Prize and plenty of money. That's great. I'm all for that, but I want you to be registered as a lobbyist and not be masquerading as someone who lives at the patient's bedside. You don't.
So you've listed pharmaceutical companies, researchers who are funded by them, NIH. Who are the other players in the medical industrial complex?
Well, clearly the hospital system in the United States is broken. After World War II, we had literally multiplied the number of nurses in this country from maybe 20,000 to nearly 150,000. The only problem we had is there wasn't much place for them to work when they returned. In 1950, if you were a nurse, your major source of employment was a hospital, and we didn't have enough hospital beds. So we set about creating 4.5 hospital beds per 100,000 Americans across America, which was great. The only problem is we didn't have enough patients to fill those beds. But of course, if you build the beds, they will come. And so we began to put people in hospitals for all sorts of things, and we kept them there a good long time. And we employed.
Yeah, I mean, in the 50s, you could be in the hospital for a week or two, whereas now you might be in for 2 days or a day.
Exactly. So the other thing that we did at the time is we relied on the American Medical Association and the American Hospital Associations to voluntarily oversee the quality of those hospitals. And to this day, we have a voluntary system of accreditation, the JCAHO. And here's the problem with this voluntary system, which largely is made up by people who have graduated from the AMA or the AHA. They're in retirement and they become inspectors for this voluntary organization. The problem with it is that when the Medicare officials, which statutorily they were required to go and examine the very hospitals that the JCAHO gave the green and bill of health to, they were required to go and double check that. They found that 30 or 40% of the time they could not validate the quality that these voluntary organizations gave. In addition, we've now moved from a time in the late 1990s where we had nearly 100,000 preventable deaths to almost now 500,000 preventable deaths in America's hospitals across the US. And that makes it the third leading cause of death in our entire country.
How does
So
that compare to other countries?
it compares poorly. And so my point being, logic would dictate something is very wrong.
Okay, well, wait, give me a statistic there. You know some stats on that. Preventable deaths in the U.S. compared to other countries. Where do we rank?
Just as we are about double in the cost, we are about double in the preventable death category, and our infection rates are very high. And we always explain this away by saying, well, you know, we have a much more complex, diverse population, but studies have not shown that that holds up. Basically, our complexity has to do with the fact that we have a tremendous overuse of technology. Our information systems are often non-compatible, and we're moving people in and out without real good controls. We're all over the map when it comes to hospitals. They're self-governed. Some are for profit, some are not, but it doesn't matter much. The truth of the matter is, as most Americans know by now, if you've got a family member in the hospital, you better put one of your family members in that room to help watch over, because things can go wrong. Wrong things can get into intravenous's, and problems can arise where nobody's there to answer the bell. Many hospitals, our nursing coverage is lower than it would be required in the past. And so, you know, we're just highly, highly variable. We don't have standardization. Just like we don't have a good health plan, we've never really asked or committed to planning or committed to the growth of public health professionals in this country. In the same way, we've never really committed to developing premier and reliably non-variable hospitals.
Okay, so we need to take a brief break now. I'm going to pause. And my guest for the show is Mike Magee, MD. He's a medical historian and journalist. He's on the faculty at University of Hartford and was head of global medical affairs for Pfizer. He's the author of Code Blue, Inside America's Medical Industrial Complex. And his website is mikemagee.org and healthcommentary.org. So I want to keep going with you on who are the parts of the MIC. You've talked about hospitals and pharmaceutical companies, researchers, and the NIH. You briefly mentioned medical device manufacturers, and you talked about how they're overused. Are there any other parties? I mean, you have a chapter that's the allies, or how did you put it, the supporters of this system, and who are the supporters and who are the enemies of healthcare for all?
Well, let's go back to the American Medical Association, because they, over the last century, have had their fingers in the system and to some extent have guided the direction that we've gone in, picked the winners and losers, and been able to align with the major corporations. The standard story of the AMA is that they evolved in the mid-1850s. They were focused on trying to get the true charlatans and the adventurers and the non-scientists who were involved in medicine out, but in fact they were protecting their own prerogatives at the time. By the 1900s, they revamped, to their credit, the quality of medical schools in the United States, but at the same time eliminated all potential competitors. They held the nursing scope of practice in check. They limited what pharmacists could do. In some cases, they were involved in biases, in racially motivated activities. Some of their members were involved in all sorts of things. But at the core of it, the AMA has, on the one hand, pursued what they consider to be excellence in care, and on the other hand, has jealously protected their own economic prerogatives.
My understanding, I was just talking last night with a physician who's been in practice for 40 years, and he said that most of the young doctors now want universal health care, and it's the older ones who are in charge of the AMA who are saying, no way, wait another 10 years, wait your turn, wait till you're in charge.
Well, I think what the AMA has fundamentally been for, as have the corporations, is the status quo, because they've done quite well with the status quo. Remember that the relationship with corporations goes way back. I mean, a lot of the money that the AMA relied on in the beginning was journal advertising. And this included advertising from tobacco companies. In fact, to the point where the tobacco companies actually had smoking lounges on the floor of the AMA conventions. The tobacco companies provide free cigarettes to pharmaceutical detail men in the 1950s who went and visited doctor's office with their product samples in hand, including tobacco. So,
and there were advertisements back then where doctors would say how healthy cigarettes were.
Well, yes. In World War II, the tobacco companies ran ads that promoted both the glory of doctors and the glory of cigarettes, usually combined in a single advertisement. I always say about my fellow physicians, we're not saints or sinners, we're somewhere in between, but we are affected by who leads us. To give you a concrete example of how far awry doctors can go, let's consider a name that's been bandied about quite a lot these days, Arthur Sackler. He was the scion head of the Sackler family, responsible for OxyContin and the opioid epidemic's beginnings, at least major responsibility. What people don't realize is that Sackler actually graduated from medical school the same year my father did in 1938. He graduated from NYU. My dad graduated from New York Medical College. And where my dad enlisted, which most of the doctors of the day did in the Army and became part of the medical corps, Arthur Sackler, like President Trump, managed to avoid going into the armed services. So what was Arthur Sackler's first job after he got out of medical school? His first job was to become the first medical director of Schering Pharmaceuticals. That's the US branch of the German Schering Pharmaceuticals, which was outlawed from selling drugs into this country because World War II had broken out. So they set up a branch, and who did they hire as their first doctor leader of that US branch? Arthur Sackler. So in 1942, the government takes over Schering as well as the other German companies in this United States, and he loses his job. Where does he go? First thing he does is join a medical marketing company. Within 3 years, he owns that medical marketing company, the top medical marketing company in the world. Within another 2 years, he's watching over 1 million psychiatric casualties that are flowing back into the US from World War II when it ended, seeing that it's filling the psychiatric hospitals. And he says to himself, psychiatry, and specifically pharmacologic care of psychiatric illness, is going to be a major profit center. So he gets himself a psychiatric residency at the Creedmoor Mental Institution in Staten Island, but he never leaves there. He establishes an institute where he's able to experiment on human patients and come up with all sorts of cockeyed ideas. But in the meantime, he purchases a small pharmaceutical outlet called Purdue Frederick. It becomes, 2 decades later, Purdue Pharma. Now, in the 1950s, who was the major client of Arthur Sackler? It was Pfizer. Arthur Sackler became the guy who was the antibiotic advertiser for Pfizer when it made its fortune in the 1950s. He also invented the notion of a detail man. He invented advisory committees, which now sit on the NIH. He was the first one to run a TV ad for a pharmaceutical, but it wasn't really for a pharmaceutical. It was for a condition called ataraxia, which he had invented. Only several months later did he release the name of a new drug to treat ataraxia. It was Pfizer's
Are you saying anorexia?
No, ataraxia.
Ataraxia. Okay.
Ataraxia was supposed to be a nervous condition, but there was no drug in the 17-minute TV ad for ataraxia. It was only 2 months later that Pfizer released its new drug, Atarax. So he was the one who invented creating a disease for which there already was a treatment waiting. He also was the one who distinguished between Valium and Librium and made both of them simultaneously $100,000 sellers. So
$100,000?
Which was a lot back then. That was the beginning. That would be like a billion-dollar seller today, but that was breakthrough at the time. So in any case, my point being this, that Arthur Sackler was at the center of the medical industrial complex. In fact, when he was investigated by Congress way back in 1962, they recognized that he was creating a vertically integrated network of conspiratorial relationships where product could be created and sold and marketed and profited from with profits shared way back in 1960.
It makes me think of RICO law.
That's right. It is RICO. And in fact, what is really amazing is that Arthur Sackler owned an organization called IMS Health. He hid his ownership when Congress went after him in 1962. But that corporation was the one that merged for the first time its database with the AMA's physician master file database so that you could predict what doctors were selling each week of what drugs. Prescription profiling was an invention of Arthur Sackler, and the AMA made plenty of money selling that master file, still does, to IMS in order to then create prescription profiles that could be sold to the pharma companies. Today, the American Medical Association makes more than half of their revenue from data products, not from membership dues, from data products. And so my point being that if you want to know how bad things can go, you can follow the early life of Arthur Sackler, and in this one physician, you can find the beginnings of all of the things that trouble us today and make American medicine essentially a racketeering operation.
And Sackler, now he's gone, but his family,
he died in 1987.
His family has continued, and they perpetrated this opiate crisis that we are now facing.
Yes, they did. And in fact, part of the marketing strategy that allowed the opioid crisis to take off was the creation of an AMA specialty organization called the American Pain Institute. And the AMA approved that without any quality control measures. And the people who are the head of that subspecialty organization ended up being the head of Purdue Pharma's medical operation as well. So by getting a specialty organization and a peer-reviewed journal created, they were able to validate this notion that we were under-treating pain, that pain was the fifth vital sign, and we needed to be much more aggressive in selling opioids and in doctors prescribing them. So in many ways, the ability for this to take off and create the problem it was, this was not simply the result of Arthur Sackler or his brothers or his nephews that ended up running the country. This was the result of the medical industrial complex. It involved the AMA, it involved the middlemen distributors, and it involved all of the pharmacy benefit management companies, and it involved the insurers who were paying for these drugs. All of them had access to the data. They saw that product was flowing in inordinate amounts to places that clearly could not have consumed it, and yet nobody blew the whistle in the early 1990s. In fact, if you take a look at who Purdue Pharma hired in 2002 to get them out of trouble with the Justice Department in the Bush organization, it was the same fixer that Trump's using now. It was Rudy Giuliani. They hired him in 2002. They sent him to Washington. He talked to Bush's justice people, and suddenly the heat was off. And as a result, we went on with this thing for another decade.
Wait a second. Let me get this straight. Rudy Giuliani early on was involved in protecting the Sackler family's opiate business?
Yes, New York Times.
So in a sense, you could say that Giuliani, by his machinations and interventions, has led to the death of tens of thousands of people.
The credit for this man-made opioid epidemic spreads far and wide. But Giuliani had a role. Had Giuliani not been able to convince Bush's Justice Department to lay off of the Purdue family, we would have pulled this thing back earlier than we did. As a result, the reason why it finally got blown wide open is that there was a report from Angus Deaton and his wife at Princeton University that basically showed that the survival curve of white males for the first time had been reversed. And they were able to track the downward cycle of America's survival of white males to this opioid epidemic.
So you've got a pharmaceutical company making profits which lead to a decrease in the lifespan of white males. This is just disgusting.
Yes.
Right, we need to take a brief break. We need to take another brief break.
Sure.
And my guest for the show is Mike Magee, MD. He's a medical historian and journalist, and he's the author of the book Code Blue, Inside America's Medical Industrial Complex. And his website is mikemagee.org and healthcommentary.org. So we've got maybe not even 15 minutes left, and I have a lot of questions that I want to cover. You've talked about the NIH. Are there other nations that have counterparts to the NIH that do it right?
Well, I think that in other countries, what we have is a research apparatus that has many more checks and balances. And we also, in every developed democracy, have health apparatuses that began by asking that fundamental question I started with, which is, how do we create a healthy population? So in other countries, there's a plan. Now, one arm of all of their plans, including a place like Canada, is research. And so it isn't that research is not important, but it's viewed as a component of one's healthcare system, not as the driver of the healthcare system.
And you write in your book that the American approach to research is kind of dumb and not very productive. Could you explain that?
Well, in the sense that because we reward straight out profitability, and because we've eliminated what would normally in the FDA be checks and balances on reproduction of drugs that are largely identical to each other, they're just varied by an atom here or an atom there, because we allow these Me Too drugs, what we have is a lot of replication of drugs. So for example, when I was at Pfizer, we were able, through a hostile takeover of Warner Lambert, to get control of a drug called Lipitor. Lipitor became the first $10 billion a year drug. What most people are unaware of is Lipitor was not the first statin to lower cholesterol. Lipitor was the fifth statin to lower cholesterol. Now, was Lipitor somewhat better than the other four? Yeah, it was somewhat better. Was it better enough that it warranted becoming a $10 billion a year gold mine? No. So my point being that just because you have a discovery doesn't necessarily mean that it is a great or important or blockbuster discovery. And yet we interpret the success of these discoveries based purely on the number of dollars that they're able to bring in. Now, what drives those dollars? Well, one thing that drives them is whether or not they're fulfilling an unmet need.
You also talk in the book, just to make sure you cover it, about research corruption.
Yes, and you know, the research corruption is basically tied to the fact that people's careers can be advanced if the research shows certain findings. This goes back to the integrated career ladder. If you're being paid $100,000 to conduct a research operation and your sponsor is a pharmaceutical company, obviously you're hoping that the results are going to be what they wanted. Now, for most researchers, if they're not, they're not. But you don't own that database. You don't own the results as a researcher. You sign off in the beginning that the research results can be published only with the approval of the company. And you also oftentimes do not have the last look at the database or even the writing of a paper before it's published, you know. So in many cases, it's been shown that ghostwriters are involved in preparing these academic papers for the physician scientists involved. And in addition, it's been shown again and again and again that companies will tend not to report out results that are not supportive of a drug, and yet they will herald and over promote results that are in any way positive. In addition, let's tie the loop back to the major medical associations that produce journals. One of the many ways that a medical association makes money is by selling reprints of articles to pharmaceutical companies that then distribute it to doctors and nurses throughout the country. So a successful product breeds successful journal articles, which breed resources to the sponsoring medical association, who sells multiple reprints of these articles for redistribution to doctors to encourage their use of these new drugs. And we haven't even discovered generics. You know, we thought generics would be the answer in the mid-1980s. We freed up some law that allowed these generics to multiply. But what we found is that the generic pharmaceutical companies are no better than the brand name pharmaceutical companies. They'll bend the rules and twist and turn in order to make a profit off of generic drugs at the same pace as any of the brand name drugs.
Okay, so we're running out of time, and I've got a couple questions I really want to cover. Why doesn't the U.S. have universal health care like every other first world nation?
We don't have it because it's been too profitable to too many people to not have it.
And who are the people and the organizations and the different categories of business that are blocking it?
The major organizations are the hospital industry, the insurance industry, the pharmaceutical industry, the American Medical Association, along with the medical education apparatus and the Association of American Medical Colleges that runs the medical schools throughout the country. And then all of the patient care associations, who by and large depend for nearly 100% of their budgets on the donations from pharmaceuticals, insurers, AMA, and hospitals.
Okay, so, next question, because I got to rush through. I want to make sure I get all these covered. A big issue centrist candidates have been raising and it's a Republican talking point, is that people will have to give up their private health insurance if there's universal health care. What's your take on this?
My feeling is that we showed in a Commonwealth study last week that whether you go for a single payer system or you have a public-private option like Buttigieg's Medicare for All Who Want It, you can afford it. You can afford to extend coverage to everybody in America who's a citizen and still save money under the current system. Now, my feeling is that the simplest way to get there is to make a public option available to all. But I emphasize to all because if you simply extend it down, let's say to age 55, that'd be too small to demonstrate that the American public, more than 70% of them, support a public approach at this point. You have to open it up and let them choose. I don't see any reason why we should have to fight the unions in order to get people off of their employer-based plans. If they want to stay on those plans, that's fine with me. I don't care. I just want to make sure that the vast majority of Americans are allowed to say to themselves, would I trust a Medicare plan for me? I think what they're going to say fairly rapidly and decisively is, yes, I will. Once that happens in large enough numbers, I think the system will trip, but it'll trip over probably over a 5-year timeline rather than create World War III and a crisis for everyone by trying to flip it all in one switch. But I do emphasize this. We have to do this in big enough a way to capture the savings. Remember, I started with the term BIR, billing and insurance-related costs. We have to have enough consolidation and enough standardization of the sale and the management of plans through a single payer of some sort in order to save this money. And that's why I say Medicare for all who want it has to be for all, not just for a small segment of the population. If we do that, we're going to face exactly what we face with the ACA. There are going to be people who are trying to kill it as we're trying to implement.
Now, Sanders and Warren are saying that you can't let some people stay out of it because that's going to end up being the people who have the least medical problems, and the private insurers are going to be able to cherry pick the cheapest people to cover. So they've got to put everybody under the basket.
And I would say that that would be right if, in fact, employers liked being healthcare managers. They don't.
Yeah, well, that's another issue. You talk in your book about how employers are at a disadvantage. You've got a chapter in your book that is the MIC tapeworm of American economic competitiveness.
Exactly. I mean, that was Warren Buffett's quote, that it's a tapeworm. It's sucking them dry. Plus, it diverts attention. Now, also remember that a lot of these employers over the past 10 years have been degrading their health insurance offerings. It looks like they're providing health insurance, but they're providing these skimpy plans with high deductibles. And the complexity of these things is so crazy that people can't even figure them out. So here's what I'm betting. I'm betting that if we truly offer Medicare for all, there will be a fairly mass exodus from most employer plans. Now, will the members of the major teachers union who have gotten incredible sweetheart deals stay put? Yeah, they'll stay put for a while, but there is no reason why those unions couldn't negotiate getting their Medicare for all plan and then allow their employers to pay supplements if they want to get those extra terrific benefits. Remember, in Canada, that national health plan only pays for 70% of the expenses. It doesn't pay for pharmaceuticals. It doesn't pay for optical care. Where do those Canadians get the money for that? They buy a supplemental plan. Over 90% of Canadians buy their own private supplemental plan. But the big difference is in Canada, private insurers are supplemental. They don't provide the major insurance for the country. In this country, we've allowed these insurance companies to be the primary provider of insurance. And as a result, as they have gotten greedier and greedier and dealt in the hospitals, the doctors, the pharmaceutical companies, they've controlled things. And the real danger now is look at the data. Who's controlling the data? And where is it being controlled from? The platform that controls data in the American healthcare system today is the Pharmacy Benefit Managing Company. Where did they get parented from? They got parented from Merck. They got parented from CVS. They got parented from United Healthcare. That tells you something. It tells you that 20, 30 years ago, these companies realized that if you controlled the data, you could control the flow of money and product. So in order for us to gain back control, we've got to gain control over our own data.
Okay, and we've got to wrap. Just the last question. Are there any issues or aspects of the healthcare conversation that are missing or ignored or not discussed that we haven't talked about here?
Well, Code Blue took 10 years to write. And the reason it took so long is I connect all of the dots. And some of the
very
dots,
thorough.
well, some of the dots that we haven't discussed is the role of the evangelical Christian movement and the Catholic Church in controlling women's rights. That is a huge story, and I'll leave it to people to buy Code Blue to get that story. We also
on my list to ask you. We've got to wrap though, so I've just got to finish it up now. So my guest for this show has been Mike Magee, MD. He's the author of Code Blue: Inside America's Medical Industrial Complex. His website is mikemagee.org and healthcommentary.org. Thanks so much for being on the show, Mike.
Rob, thanks so much for allowing me to be part of the Bottom Up Revolution.
That's great. Thank you.